स्टार्ट करें। Good evening, everyone. On behalf of IACM, I extend a warm welcome to you all. Today is the 8th of our national online CMEs. The topic this time is radiology for physicians. The wide and easily availability of CT scans now even in the remotest part of our country, the sometimes not so great quality of images and reports, and the physician's lack of training in interpreting it makes it imperative that the clinician comes to know that what he has to see, what not to miss, and what not to ignore in CT scan, and hence this CME. The guests of honor for today's program are Dr. K.K. Parikh sir and Dr. H.S. Pathak sir. Dr. K.K. Parikh sir requires no introduction at any forum. His presence alone can guarantee the success of any endeavor. Sir is past President API, past Dean Indian College of Physicians, and the current President of IACM. It was his idea to have this CME, and he has worked tirelessly and with all enthusiasm for them since day one. I will now request Dr. K.K. Parikh sir to bless us with his words of wisdom.
Thank you, Dr. MP Singh. Really, it's a great, it gives me an immense pleasure and a great honor to welcome all of you, all my friends and delegates who are attending today's CME program. Especially, I would like to extend my warm welcome to Dr. M.M. Singh, who is the founder member as well as the president of IACM, and he is the key person who was part of starting the IACM from the very beginning. I would also like to extend my warm welcome to our President-elect and Chairman Scientific Committee for the IACM National Conference at Agartala, Dr. H.S. Pathak, a very gentleman, a very great academician. Today, our chairpersons are Dr. D.P. Chakrabarti, the organizing chair or organizing secretary for the Agartala Conference of IACM, and Dr. Pradeep Bhomik, who is the organizing chairman for Agartala Conference. We all, on behalf of IACM, on behalf of Dr. Pradeep Bhomik, Dr. H.S. Pathak, Dr. Chakrabarti, we extend a warm welcome to all of you for National IACM Conference to be held at Agartala from 24th to 27th of this month, November. And I hope you have got the message, but I would again request to kindly be there in maximum number to make this conference a great success. Dr. Suresh Kushwaha is also here. He is a dynamic secretary of IACM. Today, we have got two learned and great speakers, Dr. Vinita Oja and Dr. Pooja Jain. Dr. Pooja Jain is based at the Delhi, and Dr. Vinita Oja is based at Calcutta. So these are two very learned speakers. Sorry, who will be telling us what should we see and what we should look in the CT head and CT chest, because they are the most common CT scans which is seen by the physicians. From the very beginning, we were all the time making that all these CME should be clinically oriented and should be useful for a clinical practicing physician, so that they can learn and update themselves for day-to-day problems which they face in different parts of medicine. So today we have a very good topic, that is radiology for physicians, in which we'll be talking on CT chest and CT head, and I think it will be really of great interest to our physicians, those who are attending this CME program. Our moderator and the convener of this CME program is none other than Dr. MP Singh, who has put his best efforts, hard work from the very beginning. And though the idea may be mine, but the work behind all these CME belongs to Dr. MP Singh. He is the most dedicated person of IACM. So I extend my really sincere thanks to Dr. MP Singh for organizing so many CME programs. Today is the 8th program, and I hope we'll continue in the next session also, where Dr. H.S. Pathak will be the president. But we found these CME programs to be very useful to physicians, the feedback which we are getting from our physicians. So thank you very much, and I welcome again to all of you. Thank you.
Thank you, sir. It's an absolute pleasure to be associated with you and work under your guidance and inspirational leadership. The second guest of honor tonight is Dr. H.S. Pathak, sir, another legendary physician and a clinician par excellence. He is member governing body National API, President-elect IACM, and the Chairman Scientific Committee of IACM Con. And by the look of the scientific program which we has circulated amongst all of us, it promises to set a milestone and another landmark in the annals of IACM. I would now request Dr. H.S. Pathak, sir, to say a few words to the learned audience.
Good evening, everybody. It's my pleasure to be associated with this very excellent proposed scientific topic today. I thank Dr. MP Singh for selecting this very nice topic and very catchy option. What to see, what not to see, and what to ignore. Very practical aspect of the program. It's my pleasure to be here in presence of Professor M.M. Singh, who had been the founder secretary and past chairman of president of IACM and other members of IACM. I'm thankful to Dr. K.K. Parikh for giving very sweet introduction to everybody. And I'm not taking much of time. And I will not get the time to all of you. I invite all of you, all the listeners, to join our IACM conference in Agartala, which is scheduled to be held from 24th to 26th of this number this month. So, with these few words, I request Dr. MP Singh to proceed further the program. Thank you.
Thank you, sir. We are looking forward to that great academic feast that is going to be held in Agartala. The chairpersons for today's meeting are Dr. Pradeep Bhaumik, sir, and Dr. D.P. Chakravarti, sir. Dr. Pradeep Bhaumik, sir, is Professor of Medicine at Agartala Government Medical College. He is the founder president of Hepatitis Foundation of Tripura and the organizing chairperson of IMCON 23. Dr. D.P. Chakravarti, sir, is Professor and Head Department of Medicine at Tripura Medical College. He is ex-president Tripura chapter of IACM and the organizing secretary of IACM. The moderator for today's program is Dr. B.L. Bharadwaj, sir. He is vice president IACM, former principal Government Medical College Patiala, and the current vice chancellor of M Medical University Ambala. I welcome all of you, and with this, I would request the chairpersons to introduce the speakers for today and start the proceedings. Thank you.
Good afternoon, everybody. Rather good evening, and really it is a very nice occasion today that we are going to have a discussion on city's chest and city brain or city head. And this is just 8 days before our national conference, that is IACM national conference. 29th national conference of IACM will be held at Agartala from 24th, 5th and 6th of this month. And I, on behalf of the total organizing team of IACM, welcome you all in this conference first, because this is the first time we are organizing such a big gala event at Agartala. We hope with the support of all of you, we'll be able to organize it and stage it in a very systematic manner. Tripura is one of the smallest state of the country. That is, it is the third smallest state of the country. But our heart is big, and with that big heart, we'll try to welcome you all. And we wish that all of you would please do attend the conference. Those who have not registered till now, please register and do attend the conference. And I believe the scientific committee, as Dr. M.M. Singh sir was telling, that the scientific committee has made a fabulous scientific program. Everybody will really enjoy it and have a look of the small state. Now coming to our original program, that is scientific program today, Dr. Vinita Oja, she will be talking on city of chest. And in hospitals like ours or many hospitals where we do not get the report within a very short time or after the city, we the physician has to see it, and we have to give some idea or have some idea so that we can start the treatment of the patient at the earliest possible time. So clinical, after the clinical evaluation is very important. So definitely Dr. Vinita Oja will be discussing all these issues, and we welcome her. She is one of the very enthusiastic radiologists of the country, and working with Mahajan Imaging, and did her graduation, post-graduation, and postdoctoral courses from Delhi. So we once again welcome you all, including our mentor, Dr. K.K. Parikh sir, Dr. H.S. Pathak sir, and Dr. M.M. Singh, and all Dr. V.L. Bharadwaj, and my friend Dr. D.P. Chakraborty. Now I request Dr. Vinita Oja to please start your deliberation, please.
Thank you, sir, for the kind introduction. Without further ado, I'll share my screen. Is my presentation visible, sir?
Yes.
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 I'll just put it in. So, good evening, everyone. Today I'll be speaking about basics of CT chest, and as sir was saying, we will discuss about the indications and what are the types of chest CT. We will look at what is the basic anatomy of various structures on a chest CT scan, and then we will also have a look at the common abnormalities that we see in day-to-day clinical practice, along with some examples. So if you look at the basic indications of chest CT, it is either to evaluate a mass or say a suspected chest infection, sometimes pleural diseases, pericardial pathologies, for vascular abnormalities like aortic dissection, pulmonary thromboembolism, etc. It is used for assessment of chest trauma. But these are only the few common ones in myriad list, big list of indications for chest CT scan. The advantage is that it is quick and relatively accessible. Even in the remotest part of the country, we have CT scan facilities. It provides excellent anatomical detail and fantastic localization of disease, even to guide CT-guided biopsy or drainage procedures. So the basic procedure of a chest CT scan is that once a patient lies inside the scanner, either we can go two ways. We can do a non-contrast chest CT scan, or we could do a contrast chest CT scan by injecting iodine-based contrast medium via peripheral cannula. So a common type of contrast chest CT scan that we do is a non-contrast CT scan. But if we are giving IV contrast, then the type of the chest CT scan will depend upon the interval after which we are scanning the patient after giving contrast medium. So initial is the non-contrast scan without giving any IV contrast. And if you scan after giving IV contrast, the contrast traverses via the superior vena cava, goes into the right heart. From the right heart, it goes into the pulmonary artery. So if we have to look at the pulmonary artery, we would trigger or we would scan the patient relatively early after giving contrast. So it is at around 10 to 15 seconds after giving contrast. And this type of scan is called a CT pulmonary angiogram. And this is the type of the scan that you need to order if you have to look for suspected pulmonary embolism. Next, if we wait even longer, the contrast will go from pulmonary artery to pulmonary veins and then would come back into the left heart and go into the aorta. This is when there will be good opacification of aorta as well. And this is the, usually it is achieved at around 20 to 25 seconds after giving contrast medium on a basic scanner. So this type of scan is called a CT angiogram or CT iotogram, wherein we can look at various pathologies like aortic dissection, aortic aneurysms, etc., in addition to pulmonary arteries also, which will still remain opacified. And further, if we wait even longer after giving contrast and scan the patient at around 50 to 60 or 70 milliseconds interval, then all the chambers of the heart, we will see them opacified. In addition to the contrast media will also seep into the soft tissue and will enhance the soft tissue structures also. And this is the contrast enhanced CT scan or CECT chest that we commonly order in clinical practice, and allows us to see a host of diseases that I will shortly discuss. So this is what a conventional CECT will look like. We will have the contrast enhancement of all the soft tissues, and this type of image is called the soft tissue window. And if you look at this particular image, it is the same patient, the same slice, but slight difference in the windowing is there, and we are able to see the lung parenchyma and the vessels in the lungs better. So this type of windowing is called a lung window, and it is used to assess the pulmonary lung parenchymal pathologies, whereas this type of window is more suitable for assessment of vascular structures, lymph nodes, etc., which we might see enlarged over here, etc., and also the airways. And many a times we receive this question that should we order a CCT or HRCT scan? What is the difference between a CT scan or HRCT scan? So I would like to mention here is that HRCT is nothing but a specialized reconstruction of the CT scan. So in modern day scanners, whenever we order a CT scan, there would be a provision to reconstruct the images that you have already acquired into a high resolution mode. So it is basically use of very thin section CT images, that is less than 1.5 millimeters, and we call it high spatial frequency reconstruction algorithm, but we do not need to go into that. But what it does is that it allows us to assess the lung parenchyma, including the distal most aspect of the lungs, that is the secondary pulmonary lobules, which I'll just show shortly, better. So this type of HRCT reconstructions are useful in assessment of interstitial lung diseases, in small airway diseases like COPD, emphysema, etc. But these two pictures here just show that this is the usual lung window in a patient. Whenever we do a CT scan, we can change the window setting to look like this. But this is a specialized HRCT reconstruction from the same images, and which will be made to look like a very high resolution image in order to see even the distal most vessels as well as the lung parenchyma better. So a little bit about the radiation and contrast safety in imaging. So throughout radiology, what we follow is called the ALARA principle. That is, the radiation should be as low as reasonably achievable. And this we do by, changing the values of kilovoltage and current that we use during the CT scan. But it is important to note here is that there are some pathologies, especially when the patients are on follow-up, we do not need to do a standard dose CT every time the patient is coming to us. There is something called ultra low dose CT scan, which gives very less radiation dose to the patients, that is less than 1 millisievert also. This is mainly used for patients who would come to us known benign looking pulmonary nodule is there, and we want to evaluate the patient again and again on follow-up to look for interval change in size. Then we can go for this particular scan that is called ultra low dose CT scan. And actually we do get requisitions for low dose CT scan for pathologies which can be seen even in low dose radiation dose. Regarding contrast, I want to mention over here is that because we are giving iodinated contrast medium, so although there is a lot of literature on this particular issue, but what we usually follow is that the patient should have acceptable limits with creatinine and eGFR values within acceptable limits to especially those patients who already have deranged renal function or are prone to develop acute kidney injury like diabetes, hypertension, etc. But when to order a non-contrast CT and when to order a contrast CT. So usually we do not need contrast for assessment of interstitial lung disease and monitoring a pulmonary nodule to assess COPD, bronchiectasis, etc. But what we need the contrast for is to look for any thromboembolic disease, to assess the mediastinal lymph nodes. So lymph nodes will be better seen in a post-contrast enhanced CT chest. And also for vascular malformations, aortic disease pathologies, etc., we would need contrast medium. And also for assessment of cardiac masses, if we want to characterize if it is enhancing, if it has necrosis inside it or not, or if there are any bronchial arteries which are supplying a tubercular cavity which is leading to hemorrhage, etc. In those cases, we would have to give contrast. So basically, vascular issues and lymph node issues will require contrast medium administration. So with this, I would just go into a little bit into the anatomy of the CT scan. I have the scan open over here, but it is slow. So I will just go through this. So here, we scan a bit of part of neck also whenever we are scanning so we start the scan little bit from mid neck, and they then go till the diaphragms, the costophrenic angles, which is seen in the scout images that we take. So as we go from up to down, we are able to see 4 vascular structures over here. So this enhancing thing, so this is a contrast enhanced CT. Before going into that, I'm sorry, I think I'll just mention over here is that in CT scan, how we see the objects depends upon what Hounsfield units they have, like how much density they have. So in increasing order of density, if we see air is first, that is, it appears absolutely black. So the Hounsfield unit is somewhere around -1000. We do not need to remember that, but the air would look absolutely black. And then if I just scroll down, you'll be able to see the lungs over here, because lungs are air-filled structures. They will appear black. And then we will have water-filled structures. So a little bit of CSF over here. If you see in increasing order of density, you can see water-filled structures. Little bit more than it, in density will be the soft tissue structures like muscles, intercostal planes, etc. And finally, we have the contrast enhanced vascular structures, which will be even more dense. And the densest structure that we would find would be the bones. So this is the vertebra, these are the ribs, scapula. So these are, this is going to be the order of increasing density of objects. I forgot to mention over here is that fat. So fat will be somewhere just after air. So it is, it has a Hounsfield unit of -60 to -100 Hounsfield units. So you will see them as relatively darker structures compared to muscles. So with that information in background, so if we see the 4 vascular structures here, these are the 2 carotid arteries and these are the 2 internal jugular veins. As I go down, what we will see is that the so this is the innominate artery. So let's go from here, because this is the area of thoracic outlet, which is the superior most aspect of the lungs that we are seeing. So what we see over here is that this carotid artery and here the subclavian artery, it is coming and joining to form the innominate artery over here. This is the left common carotid artery and this is the left subclavian artery. So basically these are the 3 branches of aortic arch. So if we go down, we see what we are able to see over here is a left-sided aortic arch, which is very well enhancing. And I will just follow it to show you that this is the ascending aorta, this is the descending aorta. So I'm going from up to down. So we are able to see the ascending and descending aorta here. And then we can see that this is the aortic root. So ascending aorta was originating from here. The other important vascular structure that we need to see here is this. This is the main pulmonary artery dividing into the right pulmonary artery and the left pulmonary artery. And again, if we go down, we see that the pulmonary artery was arising from this right ventricle over here. So CT, this is, or if you would be familiar with this echo, so here it is the right atrium, left atrium, right ventricle, and the left ventricle. So this is all in all the major mediastinal vasculature. I just forgot to mention the veins. So the vein that is crossing the aortic arch to come down and join the superior vena cava here. The superior vena cava lies by the side of the aortic arch towards the right side. So the vein above it would be the left brachiocephalic vein, and the other vein that is coming from the right side would be the right brachiocephalic vein. So these are the structures that we need to carefully see. And if we see the pulmonary arteries will also divide into various segmental branches and the subsegmental branches. So in addition to that, we are able to see the lungs. I will just show the lung windows again later. But what we are able to see over here is that this is the horizontal, this is the anterior junctional zone in between the two lungs. And we are also able to see the mediastinal fat in between. So little bit, all these dark structures in between are the mediastinal fat. And this rounded thing over here, these small rounded things that we will see in almost all the patients would be small lymph nodes. So we will be worried about the lymph nodes or report them when they are more than 1 centimeter in size, 10 mm. That is the usual recommendation. Otherwise, we would usually ignore subcentimetric lymph nodes, which are seen in almost all the patients. So this patient also has small lymph nodes over here and here as well. So these lymph nodes also have multiple compartments, but we do not need to go into that. And this is the black air-filled thing because it is black. So if we go down, it is the trachea, and it is dividing into the right bronchus and the left main bronchus over here. Another air-filled thing that we see behind the trachea, this is called this is the esophagus in the posterior aspect of the mediastinum. So I just wanted to mention over here is that if we multiple times we see anterior mediastinal lesion, middle mediastinum, posterior. So we just need to remember the boundaries of fibrous mediastinum, fibrous pericardium. So the heart is surrounded by this thin structure that's called a pericardium. Anything anterior to it would be the anterior mediastinum, and everything within this pericardium is the middle mediastinum, and everything posterior to the pericardium here, like the esophagus, the lymph nodes, as well as the vertebral bodies and the neural foramina, nerves, etc., they will all be part of the posterior mediastinum. So in addition to that, again, what we need to look at is the bones that I had mentioned. So we need to look at the ribs, the spinal structures, etc., and anteriorly the sternum and the mediastinum. And this is what the lung window would look like. So I had shown the lung window before. Same patient, this is the lung window. So in the lung window, what additional we are able to see? We are able to see the various vessels and their branching, etc. So these are the things that we are able to see on the lung window. So whenever we evaluate any CT scan, we try to look it at multiple planes. So this is usually called, when we look from the front view, if the patient is standing, coronal plane, and this is from the side appearance, this is called the sagittal plane. And if we see it like from the foot end of the patient, so patient is lying and we are looking from the foot end, so this is called the axial plane. And in axial plane, if we look at from the foot end of the patient, this side would be the left side of the patient, and this will be the right side. So this is very important. So left is towards this side, and this is the right side of the patient. And in addition to that, in lung windows, we are also able to see these thin lines. These are called fissures. So this is the oblique fissure of the lung. This is the right lung. So everything behind this is the right lower lobe. And this thin line over here that you are able to probably appreciate, this is called the horizontal fissure. So this is the everything above this and above the oblique fissure is called the upper lobe, right upper lobe. And everything bounded by the horizontal fissure and the oblique fissure anteriorly over here is the right middle lobe. So this is the usual segmentation of right upper mid to localize the pathologies. And on the left side, the horizontal fissure is absent. So we have the left upper lobe and the lingula over here. And we have the left lower lobe behind the oblique fissure. And this just to show that there are further differentiations between various bronchopulmonary segments for us to localize a particular lesion that we mention on the reports, but you can have a look at it at a later time. Now, I would like to mention here a little bit about the secondary pulmonary nodule, because many a times we receive requisitions for interstitial lung diseases and we say there is septal thickening. So I just wanted to mention a bit about what a septal thickening is. So the secondary pulmonary lobule would be the smallest functional unit of lung, which can be seen on HRCT. This nodule, this lobule, it appears hexagonal in shape like this, and it is supplied by the terminal most portion of the artery, that's called centrilobular artery, and adjacent to it will be the smallest portion of the bronchiole, that is the terminal bronchiole that will be supplying this. So artery and bronchus is in middle, and everything is drained via the lymphatics, which are in the periphery of the secondary pulmonary lobule. So many a times you would have come across in the report that there are centrilobular nodules. So this is what it means, that the nodules are present within the center of the secondary pulmonary nodule. And many a times in sarcoidosis, we mentioned that there are perilymphatic nodules. So it means that the nodules are present in the periphery of the secondary pulmonary lobule, that is adjacent to the lymphatics. So artery and bronchus in middle of the nodule, secondary pulmonary lobule. I'm so sorry, I mentioned nodule over here. Just sorry, I just overlooked it. And lymphatics are present in the periphery of the secondary pulmonary lobule. So this is a functional unit, and we need to remember it. Why? Because this is how we see them on an HRCT. This is just a very zoomed view, but if you can see the similarity, so this is slightly thickened septum, which is this. So in between two lobules, we have interlobular septum. So this septum is thickened over here. This is one lobule, this is another lobule, and there is a vessel inside it here, and there is a bronchus inside it here. So these are the centrilobular artery, bronchus in the center, and in the periphery, you have the lymphatics and the septum. So there, in addition to lymphatics, there are also fibrous tissues in the elastic tissues within the interstitial septum. So this is what is called the interstitial space. So the lung, if we see on a chest CT scan, is grossly divided into air space or alveoli, which will be mostly these areas, and it will be comprised of the interstitium, that is mainly formed by these areas that are in the periphery of the lobules, which is also called the interlobular interstitium or interlobular septum. So with this background in mind, let's look at some of the abnormalities that we get to see on CT chest. I have just enlisted here the most common ones. I just want to mention here is that whenever we look at a CT scan, the approach to diagnosis and what the condition is based upon the pulmonary parenchyma, upon the pattern of involvement. Suppose it's a nodular pattern of involvement, or it is a airspace infiltration, or it is a interstitial lung disease sort of involvement. So there are different patterns of involvement that lung pathologies are divided into, and that is how we guide our approach to diagnosis. And I will just show the common ones over here. So let's come to the airspace opacity. So we know now what the airspace is. That is the the middle structure of the alveoli inside the interstitium. So airspace opacities can be divided into two main types. We have heard of consolidations and ground glass opacities. So what are they? So ground glass is something like this, right? So we can see something across that particular glass, but not very clearly. So that is something called ground glass. So if the alveoli, if the air space or the center part of the secondary pulmonary lobule is filled partially by fluid and not completely filled by it, what we will be able to see is that we will see some haze, some whiteness, and we will see the vessels across it. But if you completely fill this thing by water, what it will look like is this. And then you cannot see the artery or the bronchi separately. So this is called consolidation. So this is the basic difference between a ground glass and a consolidation, that these are ground glassing because you can see some increase in density, right? This is the normal lung, and there are increased ground glass opacities over here, etc. But what we are also able to see is that there are some vessels inside them traversing. So this is only partial filling of the alveoli by water. So this was a case of COVID-19 pneumonia, and we have seen this picture so many times, and you would have seen in the clinics. So this is what a GGO is. And what a consolidation would look like is this. So there will be complete density. And in addition, what you are able to see is that you would see the aerated bronchus traveling through it. So we have heard of this term, air bronchogram. So this is what is the hallmark of consolidation. So air bronchograms can be seen traversing through this particular consolidation. So this was a case of bacterial pneumonia. And if we remember our localization, everything posterior to the oblique fissure would be lower lobe. So this was a right lower lobar consolidation, entire whiteout of the lower lobe is there. There is some consolidation anteriorly also in the middle lobe, but this is the basic difference between the two. There are various pathologies that can lead to both consolidation and ground glass opacities. What we can do on a chest CT is really say that there is consolidation, but not obviously always diagnose exactly what it was caused due to. So infections, tumors, fibrosis, a lot of things could cause it. And ground glass opacities, in addition to infection, the most common cause is pulmonary hemorrhages. They would have something like this, and viral pneumonias, and various types of lung fibrosis like NSIP, etc. can also have ground glass opacities. Just another example, another case of very nicely demonstrated air bronchograms over here with consolidation. But here what you can see is ground glass. So there is not that much whitening, but there is whitening, and this was a case of pneumocystis pneumonia. As I said, viral pneumonias usually result in ground glass sort of pattern rather than bacterial pneumonias where there is more density and consolidation. So in this patient, there are cysts also in the lungs. So this is PCP pneumonia. And then this is a case of mass in which there is consolidation and there is adjacent ground glass opacity also. So usually whenever there is this mixed, we also get these cases where there is mixed consolidation with ground glass opacities. Of course, the cause will be determined by histopathology in those cases. Now, coming to the most commonly seen infection in our country, that is tuberculosis. So usually the kind of picture that we would get is for post-primary pulmonary tuberculosis, where we would see patchy consolidation. It might show some cavitation. There would be these rounded nodular areas. There will be some linear opacities like this. And in addition to that, there can be mediastinal lymphadenopathy. So this is the hallmark picture of a tuberculosis, and we can directly say that these features are consistent with tubercular etiology as far as our country is concerned. So this is another, so the propensity for upper lobar involvement, cavitation over here, we can see various sort of nodules, linear opacities adjacent to it. There is some involvement of the lower lobe also in this case. So these are the various findings that we would get in a patient with tuberculosis. And these small nodular lesions are actually the granulomas. Another case of post-primary tuberculosis. So in addition to nodules and cavitation is here. We can see that there is an air-filled cavity. And this was seen in the last case also. In addition to that, what we can see over here is some fibrosis. You can see that there are some pointy areas like this. So this is what fibrosis or linear fibroatelectasis is what we call it, looks like. So there is some sort of scarring, retraction, some volume loss. So this is also associated with post-primary tuberculosis. I have put a picture like this over here because this sort of tree in bud like opacities like this, branching opacities is also another feature of endobronchial tuberculosis. Next, coming to another common thing that we get in our day-to-day practice, especially those working in an ICU setting, would be pulmonary edema. So initial part of the pulmonary edema is very well appreciable on chest X-rays. Whenever the pulmonary capillary wedge pressure is like from 12 to 18 millimeter of mercury, there will be capitalization of the pulmonary veins, like superiorly they will be prominent, right? And as it increases and goes beyond 18 millimeter of mercury, what you would see is that there would be interstitial thickening. I showed interstitium before, the secondary pulmonary lobule. So these are the areas that will have edema. So this is called interstitial pulmonary edema. And the X-ray equivalent of this is something like this. So these are, where you are familiar with this, this is called Curly's B lines. So this is the second stage of pulmonary edema. And this is the pathognomonic hallmark picture of alveolar stage, that is the final stage of pulmonary edema, when the pulmonary capillary bed pressure is more than 25 millimeter mercury, and we get this bat wing sort of perihilar. So this is the lung hilum. These are the lung hila from where the pulmonary artery and the bronchus are going. So around that, we will see there will be consolidations, ground glass opacities, more in the central zone. So this is called a bat wing sort of appearance, and this is the hallmark picture for pulmonary edema. But we need to remember that it can come in stages. So this is the final stage of what it would look like. A differential of this is ARDS. So this I'm just calling it a non-cardiogenic pulmonary edema for the sake of simplicity over here. So what it will show is that also areas of consolidations and ground glass opacities, but that will be more peripheral predominant. As you can see over here, there are areas of consolidations, etc., ground glassing. This by appearance, it looks that the patient would be very sick. And also, in addition to this, what you can see over here, this convex shaped structures over here are the pleural cavities. So there is fluid in the dependent position of the pleural cavity, which is the pleural effusion that is also present in this patient. In addition to this, let's look at another case, a close mimic, that is diffuse alveolar hemorrhage. I said that ground glass can also appear in pulmonary hemorrhages. So in this patient, there is extensive pulmonary hemorrhage with ground glass opacities here as well. Coming to another sort of air space opacity, that is the atelectasis of the lung. There is collapse of the right lower lobe over here. Why? Because we can see that the entire mediastinum has shifted to this side. There is opacity, and the ribs of this side are all crowded. Everything is crunched into a small space. So this is called this is what is called an atelectasis. So there is complete right lung atelectasis over here. And here it is more of segmental or lobar atelectasis on this particular side, which is more, relatively less involved segment of the lung over here. Coming to nodules a bit, I mentioned about the centrilobular nodules. So this is what a centrilobular nodule would look like. Many a times we see this, usually we call it, we give the differential of bronchiolitis. It could be due to a lot of infective etiologies, but usually tuberculosis. So centrilobular nodules like this. And if the nodules are more in the septal regions, as I said before, perilymphatic nodules. So if you see that this septa, these septal regions are having nodules here. So this is more of perilymphatic spread, and it is seen more commonly with cases like sarcoidosis, lymphangitic carcinomatosa, etc. Now, just speaking about sarcoidosis a little bit over here, in addition to the perilymphatic nodules, what we will also see is large mediastinal lymph nodes. We know of the various stages of sarcoidosis, but in this patient, we can see that there are several nodes, enlarged nodes, and in addition to that, this sort of pattern. So we are probably dealing with a case of pulmonary sarcoidosis in this case. Again, in this case, bilateral hilar lymph nodes are also present. So this was again a case of sarcoidosis. Whereas miliary tuberculosis will have more diffuse nodules across the lung, no centrilobular or perilymphatic distribution. It will be very random, doesn't obey rules. So this is what the miliary tuberculosis is going to look like, multiple nodules like this all throughout the lungs. And this is case of metastasis. Nodules of varying sizes are seen in the lungs, some large, some small, very rounded, cannonball-like appearance, and this is what a METS looks like. Coming to the final few types of lung involvement, this is what an interstitial lung disease. So we have seen what a interlobular septum looks like, the thin lines in between the septa. So if these get thickened, what we will see is something like this. So all the septa are thickened over here. So there will be interlobular septal thickening, and this is the predominant feature of interstitial lung diseases, the most common of which what we get in our routine practice is a usual interstitial pneumonia, or a UIP pattern is what we called it, which was earlier called as idiopathic pulmonary fibrosis. So we get interlobular septal thickening. So if I zoom it, you will be able to see, but okay. But there are interlobular septal thickening. In addition to that, what we are able to see is that we are able to see that there is bronchiectasis also. So these bronchi are also dilated because there is fibrosis, interlobular septal thickening and fibrosis. There will be bronchial dilatation. And in addition to that, what we are able to see is something like a honeycomb. So honeycomb is what it looks like. So we are able to see the honeycombing here. So these features are hallmark for usual interstitial pneumonia. That is subpleural honeycombing, interlobular septal thickening, and fibrosis with traction bronchiectasis. These three main features. So with that background, let's look at what the masses would look like. So as I said, for masses, you need a contrast enhanced CT to look at the pattern of enhancement. So if you see this particular mass lesion over here, what we are able to see is that there is cutoff of the bronchus over here, and there is a large mass in the CT chest, which is enhancing heterogeneously. So this is associated with a lymph node here, round lymph node, a round lymph node over here. So these are the aorta, ascending aorta, descending aorta, everything in between are nodes over here. So this patient was a case of squamous cell carcinoma, and this was a mass. Additional sign which tells us that there could be something wrong, it could be a malignant mass, is this corona radiata sign. So something, speculations, there will be rays going out of the mass lesion, something like this, speculated margin. So this is also in favor of malignancy. About lymph nodes, so as I said, more than 10 mm are significant enlargement of lymph nodes. We can see calcified lymph nodes like this. So I said bone is bright, it is very bright. So here you can see calcified, calcium, bright looking lymph nodes. So this was a case of tuberculosis with calcified lymph nodes, which can also be seen in silicosis, Kohlwerk and pneumoconiosis, etc. Another pattern of lymph nodes, if you see lymph nodes like this, so this is one big one, then there is another, and within those lymph nodes on a contrast enhanced CT, if you see there are dark areas, so you can see that there is a thin rim and inside it there is some darkening. So this is central caseous necrosis. If you say this pattern of lymphadenopathy, it is more likely to be a case of tuberculosis, which show central caseation. On the contrary, if you see large lymph nodes like this without central caseation, so it is all homogeneously enhancing like this. So this is usually seen in sarcoidosis, which is the closest mimic. So this is what we need to keep in mind. About the pleural pathology, so there can be pleural calcifications over here. And in this patient, there is fibrosis and mediastinal shift to the left side. In addition to that, we can see pleural effusion, which I have shown earlier also. But in addition to that, in contrast enhanced CT, if you see thickening of the pleura like this, and there is something like enhancing pleura, within it there is some collection, then it is most likely to be an empyema rather than a plain pleural effusion, which looks very thin-walled pleura. But if the pleura is thickened and enhancing, it is more likely to be a empyema. And this is a case of pneumothorax. I said air is black. So something very black between the bones and the lungs, in between that is air. So this is air in the pleural cavity, which is the look of the pneumothorax. Finally, regarding the airway disease, so these are some of the patterns. I have shown some of them before, but what I have not shown earlier is emphysema. So in patients with COPD, what we will get is that we will get this either centrilobular areas like this. So this is kind of a centrilobular blackish areas, which are called emphysema, centrilobular emphysema, or we can have peripheral areas like this black cystic areas or air-filled areas. This is called paraseptal emphysema. So we need to differentiate it from bronchial enlargement like this. So here you can see that the bronchus itself is enlarged. It is different from what we saw earlier. About the vascular pathologies, in the pulmonary artery, what we are able to see over here is hypodense thrombus in between both right and left pulmonary artery. And this is also causing dilatation of the right heart, right atrium, right ventricle is dilated, septum is straightened. And what you are able to see is that there is a pulmonary infarct also. So this is the case of acute pulmonary thromboembolism, and which is causing a peripheral infarct. In addition to this, it is also causing right heart strain pattern, whereas a normal heart will look like this. But here it is straightened and bowing towards left side. On the contrary, this is the chronic pulmonary thromboembolism. And how we differentiate it is that in acute, you are able to see a acute angle like this. There is a meniscus like this. But in chronic, you are able to see an obtuse angle with the vessel wall. So this is the differentiating feature between acute versus chronic pulmonary thromboembolism. And additionally, we can have a look at the calcification in the coronary arteries. Here, there is some fluid in the pericardial space, that is pericardial effusion, which we can also detect some opportunistic pathologies in the heart also while doing a CT scan. So just to summarize, we have different types of CT scan for different indications. So if we have to look for vascular pathologies, we should order an angiogram, whereas if we have to look at the soft tissues, etc., nodes, we should order a CECT. The diagnosis is really based upon the pattern of involvement: interstitial, nodule, consolidation, ground glass, etc. And we need to look at all the structures sequentially for comprehensive assessment, like chest wall, heart, mediastinum, lymph nodes, pleura, airways, lungs, as well as visualized bones should also be commented upon for proper evaluation. Thank you very much, sir.
Thank you very much, Dr. Vinita. It was really a wonderful presentation and almost a classroom teaching. So we have learned a lot many things from your discussion, and studying from the normal to abnormal, from a very acute problem to the chronic problem of the chest. So thank you very much once again on behalf of the IACM. I think we have to go for the next session. And my friend Dr. DP Chakravarti is there. We will introduce our next speaker. Once again, our sincere thanks to Dr. Vinita.
Thank you, sir. Thank you, everyone.
Good evening, everyone. Hello, I am Dr. DP Chakravarti, Organizing Secretary of IACM 2023 at Agartala. Before I invite Dr. Pooja Jain to give a talk, let me invite you to our upcoming conference at Agartala. We are eagerly waiting and looking forward to have you in our place. You know, this conference is for next 3 days from 24th to 26th. And we have got this time a very good scientific agenda. And the post-graduation participation is also going to be very excellent as far as the scientific agenda so far published. Agartala is a beautiful city, a heritage city. And I'm sure you'll all love to see these places over here. Besides science, you have a good time at Agartala. So on behalf of the organizing committee, I request all of you who is listening this webinar today, if you are not registered, please register yourself and come to Agartala. We are there to welcome you. In case of any problem, any issues which you may face during registration, please feel free to talk to me directly, personally, over my phone. You can call me up or text me on WhatsApp. We'll be happy to help assist you. We have an organizing team also, event management team, whose number is there in the website. You can contact him also at the same time. So we all, from the organizing committee side, we are looking forward really very eagerly to have you all at Agartala from 24th to 26th of this month, to have a very memorable time of IACM, which you may cherish for a lifetime. That is all our motto. Now, regarding coming to today's scientific program, which Dr. Pooja Jain is going to talk about CT brain. To give a brief introduction of Dr. Pooja Jain, she is from Delhi. She did her undergraduation from MMC, Maulana Medical College. Then she did her post-graduation from Safdarjung Hospital. And now she's attached to Mahajan Imaging as a consultant radiologist. The topic is quite important, as Dr. Pradeep Bhaumik has highlighted at the very beginning. We physicians have to do CT scan without a report most of the times. We cannot wait for a radiologist to report. And there are some things sometimes we also see. We miss sometimes some important things which comes on CT scan. The subtle problem CT scan is sometimes missed by us. When the radiologist reports it, then we try to see it, oh, it's there. So I'm sure that with her deliberation, we'll all benefited to miss, not to miss those important things which we miss many times in our normal daily rounds. So I invite Dr. Pooja Jain to start her deliberation. Thank you very much.
Thank you, sir, for the introduction. I'll just share my screen. Is my screen visible?
Not yet.
Okay.
Yes.
Yeah.
Not visible.
Okay. Okay, so today I'm going to talk about CT head. It is mainly an approach-based talk, and I'll mostly be covering the NCCT head in an emergency situation, as that is the CT which requires the most urgent interpretation for reducing the time for management and thereby bettering patient prognosis. The indications for neuroimaging are diverse. They range from traumatic to non-traumatic causes. And currently, the two main neuroimaging modalities that we have are CT and MRI. Dr. Vinita has talked a bit, but I'd just like to add to it. CT was initially first developed by Hounsfield and Cormack in the early 1970s, for which they received a Nobel Prize in 1979. Now, what exactly is a CT? They're just rotating X-rays. So whereas in X-ray, the X-ray tube is stationary, in a CT scan, it rotates around the patient 360 degree, taking images all throughout. Over the years, there have been several developments and advances in CT technology. So while initially we used to have a very thin beam, single detectors, not even covering the entire patient, now we have large fan beams with multiple detectors almost completely surrounding patients, in which we acquire very high quality images and 3D data sets that can be then reconstituted in several planes like sagittal, coronal, and axial. The two basic types of CT heads, the non-contrast and the contrast. The non-contrast is mostly the most commonly ordered head imaging, which is done in the emergency situation. It scores over MRI in its availability, speed, and even cost. It provides information about hemorrhages, infarctions, masses, edema, and several other abnormalities. For contrast CT, an intravenous contrast is injected usually in the upper arm. And then depending on the delay of imaging, it can either be an angiogram in which we see the arteries, or it can be a venogram in which we see the veins. Further, perfusion imaging can also be done in which we map the blood flow through an area. Contrast imaging is also helpful in assessing vascular abnormalities like aneurysms, malformations, sinus thrombosis, demonstrating neoplasias, infections, and inflammations. Now, drawbacks, as Dr. Vinita has rightly pointed out, the major drawbacks would be radiation and contrast reactions. In a CT head provides around 2 millisieverts of radiation exposure, which is equivalent to around 100 chest X-rays and also 8 months of background radiation. Further contrast reactions, when only in contrast CTs, that is, they range from mild to severe. They can be acute or delayed. So these are the major drawbacks that we need to keep in mind whenever ordering any CTs. Now, again, as Dr. Vinita said, CTs are based on differential attenuation of X-rays. Now, how it is? Any material which completely blocks these X-rays, that is, attenuates them more, will be white. And that is what we call as hyperdense on CT. Any material which allows most of the X-rays to pass will appear black. That is what we call as hypodense on a CT. And for describing these radio densities, we use the term Hounsfield unit, that is the HU. As we can see on this scale here, on the right end, we have the cortical bone, that is bones which completely block X-rays to a major extent and have a HU of around more than 1000, and they appear white on a CT scan. On the opposite end of the spectrum, we have air, which allows most of the X-rays to pass and appearing black, that is giving an HU of -1000. Right in the middle, we have water with an HU of 0, appearing black but different than air. And next to water, at around 30 to 45, we have most of the soft tissues. And I'll just put in a slide here. So these are different CT head images representing these attenuations. So here on the left, we have air in these maxillary sinuses and in the mastoid that we can see appear black. On the right, we can see we have cortical bone here, which is appearing white because it is blocking most of the X-rays. On the top, we have brain. Here we can see the parenchyma, the CSF and the ventricles. All this lies in a HU around 0 to 45, so soft tissue HU. On the bottom image, here we see blood, that is hemorrhage. Acute hemorrhage usually lies around 60 to 90. On the top here, this is a contrast image. Here we can see bright appearing middle cerebral arteries. So contrast attenuation depends on the volume of contrast that is injected and also the speed by which it is injected. Of note here is fat lies on the minus spectrum. That is, the attenuation of fat varies around 30 to 50. On the brain, we need to identify the gray-white matter differentiation, which is very important because any time this differentiation is lost, we need to look for some abnormality. Now, normally gray matter on a CT appears slightly brighter than the white matter. Now, why is this? Is because the gray matter contains nuclear bodies, whereas the white matter contains the myelinated axons, and myelin contains lipid. And that we have already seen that lipid has a minus attenuation. So that because of lipid, the attenuation of white matter is slightly lower than the gray matter. Now, windowing. What we see in brain, usually we use two windows, that is the brain window and the bone window. On the left, we see the brain window, and if you can see this bar here, the setting has been done from 0 to 100. And as we have already seen previously that most of the soft tissues in the brain lie between around 0 to 45, bleed is around 90. So we're talking anything between 0 to 100. So what this windowing helps us to do is differentiate all these closely placed densities separately. So here we can see blood, that is a subdural hematoma, the brain parenchyma, and the CSF and ventricles all separately. Now let's look at the bone window. Here we have whited out everything. So here the scale is from minus 450 to 1000. So here we can only see the cortical bone, which has an HU of around 1000, and rest everything has become gray because it lies in a very narrow range in the middle of this bar here. Let's take this example here. Here we can see that there is an epidural hematoma along the left frontal convexity and some bleed within the ventricle. Now we cannot see any fracture here in the bone because the bones have been whited out. On the other hand, on the bone window, we see there is a thin fracture on the left side of the frontal bone, but on this image, we're not able to see the bleeds. So both windows have to be assessed while looking at any brain CT. Now the right-left orientation on a CT, conventionally, the right of the patient is on the left of our screen and the left of the patient is on the right. It is taken as if we are standing on the foot end of the patient and facing the patient. That is how we conventionally take it for most of the radiological modalities. The symmetry, brain symmetry is another very important finding which we need to always assess because symmetry usually, but not always, indicates normalcy. So across this imaginary midline, the brain contents like the parenchyma, the ventricles will usually be symmetrical on both sides. Some pathologies like edema, hydrocephalus may appear symmetrical, so it's a usual thing, but not a rule. So generally, asymmetry can indicate pathology. These are some few examples. So here we can see there is a subdural hematoma here, there is an epidural hematoma here, which is compressing the brain parenchyma and shifting the brain to the opposite side across this imaginary midline. Now on the CT, we can assess this degree of displacement, and greater the shift, more likely the patient is to benefit from decompression. If the shift is too much, like there is too much pushing of the brain parenchyma, it can result in several brain herniations. For example, brain herniations may lead to secondary comorbidities, like it can cause pressure necrosis, compression of cranial nerves, vessels. And below in this image, we can see different types of herniation. For example, we see extracranial herniation, subpalcine, a transtentorial herniation, and a tonsillar herniation. Let's look at some examples. This is subpalcine herniation is the most common type of herniation. In this, the cingulate gyrus herniates below the falx. This is the falx. The cingulate gyrus herniates below the falx to the opposite side. It is here in this image, we can see it is herniating. It is compressing the left lateral ventricle. The right lateral ventricle is slightly prominent. And as we discussed, these herniation may lead to compression of arteries. And here we can see that the pericallosal artery has been compressed along the falx. So this will further lead to several vascular comorbidities. The next most common type of herniation is the transtentorial herniation. In the first image here, we can see that the left uncus has herniated into the perimesencephalic cistern. Normally, we'll see in later slides that normally we have cisterns around the brainstem where CSF flows easily. But here we can see we do not see anything. There is complete effacement of the cisterns. There is compression of the midbrain. There is mild prominence of the right temporal horn and complete compression of the left temporal horn. And all this is happening because there is a left temporal subdural hematoma in this area. This is in the second image in the middle. We can also see there is some herniation of the right uncus into the perimesencephalic cistern, leading to widening of the cistern. Again, there is mild compensatory prominence of the left temporal horn. And again, here we can see some subdural hemorrhage. As already said, in the case of transtentorial herniation, there is a risk of compression of the posterior cerebral artery and also of the oculomotor nerves as they traverse through the cisterns. Now, some rarer herniations that we see are extracranial herniation. Extracranial herniations usually occur across any postoperative defect or traumatic defect, and the brain is usually swollen either due to edema or due to any other masses in this area. This is a paradoxical brain herniation, also called as sinking skin flap syndrome. This happens when the atmospheric pressure becomes more than the CSF pressure. So it pushes the brain inside, and this can further lead to subpalcine and transtentorial herniation and is a potentially fatal condition. This can happen when there is a risk of either there are CSF leaks or there is or in a follow-up of a lumbar puncture. Once we are reading CTs, we should also be aware of some artifacts which may obscure images, degrade image quality. This could be motion artifacts. They can be streak artifacts from beam hardening, artifacts from metal densities. The advantage of faster scanners, the recent scanners, are they're very fast. So they acquire images so fast that they reduce the chances of motion artifacts in the scans. Now, what is the brain checklist? Now, whenever we're looking at a CT brain, we need to identify certain areas. Gradually, we all make our own checklists and we all have our own orders. So just that we cover all compartments, we include brains, ventricles, cisterns, the blood, the bone, and some review areas in and around the brain. So in the brain, we look for symmetry, the gray-white matter differentiation, any shifts, any hyper or hypodensities which are extra from the normal, any air within the brain where it should not be, any masses in the brain. In the ventricles, we look for shifts, effacements, any blood, any dilatation of the ventricles. Cisterns, again, we are looking for compression, we are looking for blood. Blood, we are looking for multiple compartments for blood, which I'm going to cover later. Bones, we're looking for fractures, we're looking for lesions. So now blood. Acute hemorrhage appears brighter than the brain. As we've already seen, it comes in the HU of 60 to 90. As time elapses, blood darkens and gradually its density decreases. That is, it becomes blacker. Why does it happen is because of absorption, changes in oxidation and dispersion of blood in subarachnoid spaces. So here in this image here, we can see a very thin right temporoparietal subdural hematoma, which is bright, indicating it's acute right now. In the middle image here, we can see some hypodensities here along both cerebral convexities, indicating a little more chronic hemorrhage here. And in the last image here, we are seeing some dependent brightness here and some blackness here and some intermediate signal in the middle, indicating it is containing blood of several stages. So some acute component in the dependent part, not a chronic component in the non-dependent part. Just a side note here that in the middle image here, how do we even know whether something is here or not? Because there is such a thin hypodensity here, it could just be normal and atrophic. So this is when the cortical vein science helps us to find this out. So here, if you can appreciate, these are the small punctate white colored structures. These are the cortical veins. This is the contrast CT. Normally, cortical veins traverse very close to the inner calvarium, almost abutting it. So they should be near the inner calvarium. Whenever anything comes in the extraaxial space, it displaces these cortical veins from the inner calvarium towards the brain. So that means whenever there is widening of this space, we should always look for cortical veins, whether they are traversing around the inner calvarium or are they displaced more medially towards the brain. If they are displaced, we should look for something abnormality in that space. For reference, this is a CT scan of an atrophic patient. We can see that the sulci are a little widened, the ventricles are widened, the extraaxial CSF spaces are widened. Again, whenever there is something extraaxially, it will compress the brain and result in effacement of the sulcal spaces. So that can also give us a hint whether it is an atrophy or are we looking at something which is compressing the brain from outside. Blood can be in several spaces in the brain, as we'll see. Now, this is an epidural hematoma and a subdural hematoma. Epidural hematomas are biconvex, lenticular-shaped hematomas. They're located between the dura and the bone. They are usually due to arterial bleeds and therefore fast to form and cause more mass effect earlier. They do not cross sutures, but they can cross the midline. Subdural hematomas, on the other hand, they are crescentic-shaped. They are located between the dura and the arachnoid. They are mostly due to venous bleeds and therefore relatively slower to form and do not cause major mass effects initially. They can cross sutures, but they cannot cross midlines. They are limited by dural folds. Subarachnoid hemorrhage is hemorrhage in the subarachnoid spaces, which include the basal cisterns. These are all the perimesencephalic, the suprasellar cisterns, the sylvian cisterns. The ventricles, they can be located in the ventricles and they can be located in the sulcal spaces. Intraparenchymal hemorrhages can be located within the parenchyma. They can be traumatic or they can be hemorrhagic. There are very specific sites of hemorrhagic bleeds. We usually find them in the basal ganglia, the thalamus, the pons, and the cerebellum. So bleeds in these locations without history of trauma mostly point towards hypertension. Now, just a side note here again, like in this we saw there is a hematoma in the left frontal parenchyma, but there is also a calcified mass here and they're both appearing white. Now, how do we find out whether what is calcification and what is bleed? So calcification should not be confused with each other. How do we see that? We can see that because calcifications remain bright on bone windows. So if we look at the top image here, this is the choroid plexus calcification in the left lateral ventricle. And when we shift to a bone window, it still remains bright. So supporting that it might be a calcification. And if you can appreciate, there is a very small meningioma here along the right temporal convexity, which is showing calcification. And when we shift to bone window, we can still see some brightness here, which is the calcification component. On the other hand, bleeds, like in the lower image here, we see the epidural hematoma. And when we shift to bone window, we do not see it anymore. So bleeds will usually not be seen that well on a bone window, whereas calcifications will be seen. Because calcifications have a very high HU reaching near bone, they may reach up to 1000, whereas bleeds, as we've already seen, remain around 60 to 90. Again, pineal gland, choroid plexus, and meningeal calcifications. These are physiological calcifications which are seen at very particular sites, and so they can be differentiated from bleeds. Now, ischemic stroke accounts for around 85% of strokes, and it is potentially one of the most important indications where interpretation by emergency physicians might play the greatest role in shortening time to diagnosis. Now, how early can we see signs on a CT after ischemia? The National Institute of Neurological Disorders and Stroke says it can be less than 3 hours, and not 6 as we've usually seen. Now let's look at some early CT findings of acute ischemia. How do we identify it on a CT? The first sign is the hyperdense vessel sign. Now, what is a hyperdense? Hyper means bright, that is white. So what is a hyperdense vessel sign is that we are directly seeing the white thrombus in the vessel. It is mostly seen, best seen in the middle cerebral artery, that is the MCA. So in this image, if you appreciate on the left, this is the linear thing, that is the MCA, and this white, it is white because there is a thrombus in it, called as a hyperdense MCA sign. On the other hand, on the right side, we do not see any such brightness and the vessel is traversing normally, indicating there is no thrombus in that vessel. Next, the loss of gray white matter differentiation. We've already seen that white matter is slightly blacker compared to the gray matter because of myelin and lipid content of the white matter. Now, what happens in ischemia is fluid shifts take place. So gray matter gains fluid, white matter gains fluid, and this difference of attenuation between the two structures decreases. So here we can see this is the normal brain where we can see some gray matter is whiter and the black matter is a slightly blacker. Here there is loss of gray white matter differentiation. So it is all looking homogeneously slightly darker. Here again there is loss of gray white matter differentiation. Here again there is loss. So loss of gray white matter differentiation is also one of the early signs of ischemia. As a part of loss of gray white matter differentiation is an insular ribbon sign. Now, it is seen in an MCA infarct, that is an MCA thrombus. What is an insular cortex is, it is located just below the sylvian cistern here, this thin, very thin, bright gray matter that is there. Now, insular cortex is highly susceptible to early ischemia is because it does not have collateral circulation. So here we can see this whole blackness that is there, and we do not see that bright band in this insular area, indicating there is loss of the gray white matter differentiation in this area, indicating that there is some component of ischemia. Now, ischemic brain looks hypodense. As time progresses, the ischemic brain, the hypodensity also keeps increasing. And so as we see that as time increases, it becomes more black, the ischemic area. Now, a side note here would be that how do you differentiate the blackness of ischemia from the blackness of edema, as they both appear hypodense on a CT? This is because edemas do not conform to vascular territories. In the brain, we have definite vascular territories for as blood supplies with some overlaps in the border areas. But overall, they're broadly segregated. So here in this image, we can see there is a very well demarcated left MCA territory infarct. It is not going to ACA territory or in the watershed areas. On the other hand, here we have edema. There is some lesion here, and here we have edema, which is just randomly moving in the white matter of the brain. Another finding which we can help us differentiate ischemia and edema would be that ischemias usually involve both gray and white matter, whereas edema usually involves mainly the white matter. So it gives these finger-like projections into the brain. Now let's look at cerebral edema. This is normal brain for reference on the left. Now here in cerebral edema, there is swelling of the brain. So when brain swells, it becomes darker. There is effacement. So normally we see all these ventricle sulcal spaces. There is complete loss of these ventricles. The sulcal spaces, they are completely lost. We just see parenchyma, which is gone in all these spaces. And there is a sign which we call as the white cerebellum sign. So this is the cerebellum that we are seeing here. Now, because the rest of the brain becomes hypodense, that is blacker because of edema, the cerebellum relatively becomes brighter. It is said that the white cerebellum sign is a potentially poor prognostic factor in case of cerebral edema. Now, how do we differentiate extraaxial and intraaxial on a CT? Sometimes it is very easy when masses are small. For example, here we can see a small vestibular schwannoma in the left cerebellopontine cistern extending into the IAC. But when the masses are large, there is a lot of confusion. There are some signs which help us in this. Now, whenever the mass is present, extraaxial is when a mass is present outside the brain, intraaxial is when it is present in the brain. So masses outside the brain will take some space and therefore will compress the brain. So we'll be able to see a thin rim of gray matter still surrounding the mass. There will be buckling of the white matter. There will be shifting of the parenchyma. Again, we might see, these finds are definitely much better appreciated on MR, but CT can no less tell us many of these changes. A CSF cleft may sometimes seen between the mass and the brain parenchyma, indicating that it is outside the brain. Then we can also see some underlying bone changes here. There can be erosions, hyperplasia, hyperostosis. And as we have also already seen that cortical veins traverse close to parenchyma. So any displacement of cortical veins towards the brain would always indicate something outside the brain. Now, some structures appear bright on CT, some structures appear black on CT. That is how we differentiate. So structures which appear bright, that is hyperdense, include a thrombus, which we've already seen as a hyperdense MCA sign, a bleed, which we've already seen, and calcification. Here we see some basal ganglia calcifications. Structures which appear black on CT include air. Now that is called as pneumocephalus. So here we see a lot of air in the brain. It is there in the extraaxial spaces. It is there in the ventricular system. It is there in the sulcal spaces. So this is called as pneumocephalus. Then hypodensities can also be caused by fat, because we've already seen that fat gives a low HU of around minus 30 to 50. So it will give black appearance. So this is a case of a right temporal dermoid cyst. So in this, we can see this black lesion which is there. We can also see a small speck of calcification here. And again, as we've already seen, edema and ischemia, they all look hypodense, that is blacker on CT. Now, this is just a visual representation of some of the masses that we see within the brain parenchyma. These can range from infection to malignancies. So starting from the left, this is a peripherally enhancing abscess in the left frontal parenchyma with some edema around it. The middle images show multifocal tuberculomas in the brain. They're all peripherally enhancing. On the right top, we see some large chunky calcifications which are appearing white on CT. These were two cases of oligodendrogliomas which showed calcifications. The bottom image shows a very heterogeneous mass which is showing enhancement and significant edema, that is blackness, which is finger-like projection, so indicating edema around it. Now, sometimes we might not see the mass, but there might be secondary signs of something happening in that area that might point towards it. This is a normal CT scan for reference. Now, here we can see that both lateral ventricles are closely opposed. There's nothing in between. Whereas in this CT slice, we can see that they are being separated by something that is going on in this area, though we are not able to see what exactly it is. On giving contrast, we see that there is some contrast enhancing mass lesion which is separating both these ventricles. So secondary signs may sometimes help to identify primary masses. Now, neoplasms usually secrete growth factors. They have neovascularizations, and these vessels are usually leaky. So they lead to extravasation of fluid, which usually leads to edema around these masses. This also contributes to enhancement, which we see around these masses because of neovascularization. Now let's look at what happens to some of the abnormalities of ventricles. Here we can see ventricles can undergo effacements and shifts. Here it is due to some hemorrhage. It can be due to masses. Here we see some bleeds in both the ventricles. Now here, when ventricles dilate, it can be either obstructive or non-obstructive hydrocephalus. So here in the top corner, we see both the lateral ventricles are dilated, the temporal horns are dilated, but the fourth ventricle is not dilated, indicating that it is an obstructive type of hydrocephalus. On the bottoms here, we can see that the fourth ventricle is also dilated, indicating that it is a non-obstructive or a communicating type of hydrocephalus. However, the word communicating is a little under the radar, and they say that usually some obstruction is there, not in the brain, but might be in the spinal axis, which is causing this hydrocephalus. Now, let's look at a brain where the ventricles are prominent, but it is not hydrocephalus. So how do we differentiate hydrocephalus from an atrophic brain? So here, this is an atrophic brain. As we can see in hydrocephalus, the dilated ventricles cause mass effect, and there is diffuse effacement of the sulcal spaces. We can see no sulci here. We can see some haziness, which is there on the ventricular margins, which is the ooze, the periventricular ooze. On the other hand, this is the atrophic brain where we see prominent sulcal spaces, the ventricles are prominent, and there is no ooze. So that is how we differentiate a hydrocephalic brain from an atrophic brain. Now, cisterns are CSF spaces which are there on the base of the brain mainly. The major cisterns would be suprasellar cisterns.
Dr. Pooja, your slides are not moving. We are still on that obstructive and non-obstructed hydrocephalus. Now it's moved. Thank you.
Is it moved, sir?
Yeah, it is.
Okay. So I was talking about cisterns here. So many cisterns surround the base of the brain. So here we see some of the major ones. That is a suprasellar cistern. It is a star-shaped cistern anteriorly. We see the perimesencephalic cisterns around the brainstem. These include the interpeduncular, the crural cistern, the ambient cistern, and the quadrigeminal cistern. And then we see the sylvian cistern. Now, what are the pathologies is that the cisterns, there may be blood in the cisterns or they may be effaced. Now, in the first image here, we see this diffuse brightness which is there in the expected CSF signal of the cisterns. This is diffuse subarachnoid hemorrhage. In the absence of trauma, presence of such kind of hemorrhage points towards a very high probability of an aneurysmal rupture. And in this case, an emergency CT angiography is what is warranted. In the second image here, we see, this is a normal brain. So we see the CSF in the cistern normally. This is the perimesencephalic cistern. And here in an edematous brain, we see that it has been compressed and effaced. Now, while reading a head CT, we also have to look at the bones. Bones mainly in a traumatic setting where we're looking for fractures. Now, here on the left image, we can see some cortical breaks here and here. Now, these are fractures. The one thing we need to keep in mind when identifying fractures is, are they sutures or not? How do we do that is, we compare it to the opposite side. So sutures will always be symmetrical. There'll be, if there is one here, there'll be one here. So here we can see that there's no break on the left side, indicating that these are fractures. On the other hand, if we see this image, we can see one break here, but we can also see one break here, indicating that these might be sutures rather than fractures. With practice, we kind of understand which ones are sutures, which are fractures. We can also see fractures here, which are involving the facial bones here and facial bones. Now, sometimes we do not see the fracture, like these are very overt fractures, but there might be secondary signs which may hint that there might be a fracture in this area and we should look more carefully. So, for example, air where it should not be there. So here we see these punctate foci of air in the soft tissues. We see one focus in the orbit. We see few foci in the extra axial space of the brain. And these air foci should not be here normally. So why are they here is because they're pointing towards some bony injury in this area. In this image, we can overtly see fractures of the left greater wing of sphenoid and the lateral wall of the left orbit. But sometimes these fractures are very thin and very difficult to see. So these findings provide a hint that there might be a fracture in this area. Again, another hint that we find is in the sinuses. Now, if the sinuses are normally should be filled with air, if there is fluid in a sinus in a setting of trauma, it highly indicates that that might be a small fracture in the wall, and we should definitely go back and look for it. Now, apart from traumatic setting, bones of the CT head might also show some other pathologies. Like, for example, here we can see some radiolucencies, that is lytic defects within the bone. These were actually venous lacunae, and on the MR, we see some arachnoid granulations which were causing these lucencies. In the middle image here, we can see an intraosseous hemangioma showing its stippled appearance. Here in the top image, we see a lesion which is widening the diploic space. The margins are very sharply defined and lobulated, scalloped, indicating that it is some benign lesion rather than any aggressive pathology. This was a case of an intradiploic epidermoid cyst. On the bottom image here, we see many lytic lesions which are there in the calvaria. Now, contrastingly, the margins of these lesions are very hazy, irregular, indicating that it is some aggressive pathology, and rightly this was a case of a metastatic brain calvaria involvement. Now, as we've already discussed, that air spaces should be filled with air. That is, the sinuses, the mastoid air cells should always have air. If they are not, if there is no air and it is replaced, it might be due to pus, mucus, blood, and in the setting of trauma, definitely warrants a look back for a thin fracture. Just concluding my slides with a few two images on contrast. This is a CT angiography image, that is when we image after providing contrast to see the arteries. As I've already said, that subarachnoid hemorrhage in the basal cisterns, not in the setting of trauma, should warrant to look for a ruptured aneurysm. And rightly, in this case of extensive basal subarachnoid hemorrhage, there was a very tiny, if you can appreciate this dot here, the red arrow is pointing, pericallosal aneurysm which had ruptured and caused that hemorrhage. In the bottom slide, we can see a left middle cerebral artery aneurysm in all the three planes. So modern CT scanners provide us thin images and allowing us a lot of manipulation on the console. On the right, we see some abnormality which is happening here on an NCCT brain. On providing contrast, we can see a tangle of vessels that was the nidus of an arteriovenous malformation. Now, these are some venography images which allow us to see the veins, the cortical veins and the dural sinuses. Now, sometimes we can identify clots in the sinuses. This is an NCCT image, and as we've already seen that clots appear bright, that is whiter than the brain. And here we can see there is some brightness that is in the superior sagittal sinus. This might represent a clot. However, sometimes the sinuses baseline appear brighter on a CT, and it is always better to look at how the other sinuses are looking. Because if all the other sinuses are also looking bright, it is mostly normal for the patient and not a clot. Now, what helps here is a contrast venogram where this thrombus is seen as a filling defect. So this is called as an empty delta sign. So we see some margination of a triangle of contrast and there is some filling defect inside. So this better shows the thrombus in any superior sagittal sinus. So what is the Monro-Kerry doctrine states that there are three components of brain, that is the blood, the CSF and the brain tissue, and they are in dynamic equilibrium with each other. Whenever volume of any one component increases, the other two try to accommodate it till an extent beyond which it leads to increased intracranial pressures. For example, if there is a tumor in the brain, the CSF and blood might decrease a bit to accommodate it. If the CSF increases due to hydrocephalus, the other two compartments might decrease to accommodate it. So a few take-home points from my side, it would be, you should always compare the left and right. As we talked about symmetry, asymmetry usually, but not generally points towards asymmetry. Look carefully that the sulci are abutting the inner table. As we've seen, if there is displacement of the vessels, if there is something there, the displacement of vessels point that there might be something in the extraaxial spaces. Look carefully at the glass fluid sites near the vertex, as sometimes the pathology is only higher up and we might miss it if we don't see these sections. Check the bone windows. Look for places where fluid shouldn't be, like the sinuses and the mastoids, and look at the facial skeleton. Thank you so much.
Dr. Pooja, hello.
Yes, sir.
Can you?
Yes, sir, I can hear you.
Can you see one or two fourth ventricular cyst? Because I lost one came to me with headache, and I asked for the CT scan during the night. The radiologist was not available, so technician did it, and I saw it was normal, and according to technician, it was normal. But later on in the morning, when it was reviewed by radiologist, he said the fourth ventricular cyst. By that time, the lady was dead.
It was a ventricular cyst, sir. Did I hear that right?
Fourth recognize it.
I'm sorry, sir, I lost your voice. Was that a ventricular cyst? Did I hear that right?
Yeah.
Okay. So ventricular cyst leading to death seems a little we also don't see it generally. Ventricular cysts normally are benign. Most of the cysts that we see in majority are usually benign. Where exactly was the cyst, sir? Which ventricle?
Fourth ventricle.
Okay. Was it causing hydrocephalus?
I don't know. It was causing a headache for 3 days.
Okay. It seems a little unlikely for a cyst to suddenly appear and cause headaches, especially a fourth ventricle cyst is a less common cystic lesion. Usually we find benign cysts in the lateral ventricles. Fourth ventricle cyst leading can definitely, if there is a cyst there, it might cause headache because it is causing some obstruction to CSF flow, but might not have been the cause of death, sir. I'm not sure, but it's one hint in identifying any lesion in that case would be that the ventricle would have been prominent, sir. It would be dilated, I feel. Because if something is occupying anything within a space, it will definitely expand it. That should have been, maybe that was what, maybe it wasn't, it was a small cyst, not very much expanding the ventricle. That's why maybe it must have come off as normal in the first go, maybe.
No, actually, the film was not examined by radiologist. It was
Okay.
technician. And I was not conversant with this entity. So
no, sir, sometimes we have the advantage of consoles. Consoles really help us a lot. Films versus films. When we have those thin sections on console, hopefully in the future it will be like this, and you also will be able to provide images in CDs and consoles so that you also can scroll. Because sometimes very minute abnormalities are there which we can only see on console, and sometimes because the technician makes films, it might not even have come on the film, sir. That could have also been the cause. We usually, because that was rule number 1 when we were taught radiology, we used to write all these calcified granulomas in our report, and our consultants used to always check films and tell us, do you even see it on the film? And most of the times we were not able to see them because the technician had cut that section off the film itself only. So that might have been that maybe it did not come in the film only, that section, and they saw it on the console and saw there was a cyst. This is a major drawback, sir, which happens. This communication gap definitely happens in our routine clinical practice.
do you have any film of fourth ventricular cyst which I can see now?
Not. I don't have a case per se, but if you want me to pull it off the net, I can do that. I'll just show you, sir. 1 second. I'll just share my screen. 1 second, sir. Yes.
Can't see it yet.
No, it's just coming, sir. Just 1 second. Yes, can you see it now, sir?
Yeah, we can.
So this is all I've just pulled up from the net, sir. These are all like fourth ventricle cysts. So as we can see here, like anything which will, if it is of adequate size, like if it is very tiny, it will definitely not do anything. It will be difficult to find, sir. But anything which is there in any space will create some kind of mass effect. So we have lost the normal shape of the fourth ventricle here. It has become rounded here, as we can see. Like here, it has become some lobulated irregularity type of thing is there in the fourth ventricle. It has lost its normal shape, that the normal fourth ventricle shape that we see. So this can definitely help us identify any abnormality in any space of the brain. Like for example, here also, the fourth ventricle, it is widened. There is something that is happening here. It might have been widened due to hydrocephalus. We need to check other ventricles. Or it might have, or then in this case, definitely there is an SOL here. We can see on the sagittal image. So definitely change in the normal shape of any structure might indicate something abnormal going on in that space. But I'm still feeling that maybe that section got cut off the film, sir. That is very commonly seen in our practice.
Quite likely. An excellent presentation, Dr. Pooja Jain. One of the best I've ever heard. I've been listening to CT Brain for the last 15 years as a neurologist. This was the best lecture I've ever heard.
Thank you so much, sir. That's very kind of you, sir.
Absolutely. And could you please enlighten the audience that how can we differentiate between a chronic subdural hematoma versus a chronic subdural hygroma? If it is
So we
possible on
cannot.
CT.
We cannot.
cannot.
Sometimes we just give that differential until and unless. So hygromas, as we know, it's fluid. It's water. So only sometimes when the hygroma is sometimes when the chronic subdural hematomas, then might be some inhomogeneity. Like it is not as clear as water. That might give us a hint that it might have been a hematoma which has gone chronic rather than a hygroma. But there are instances, sir, we give both differentials. We cannot differentiate mostly. We cannot differentiate in cases in which they're both completely black.
We are really looking forward to have you as one of the speakers in our annual conferences. Maybe
Thank
next
you so
time, if not this time.
Sure, sir.
Thank you. Now
Thank
I would.
you.
Dr. Vinita is probably not here. She was saying that she had some other appointment at around 9. She had to go somewhere. And now I would request Dr. Parikh sir to propose a vote of thanks. If anybody wants to say anything, is most welcome to say so before Dr. Parikh starts.
Excellent deliberations. I think we could have wonderful Pooja ma'am. It has been a great lecture and
Thank you so much.
very nicely explained each and everything. And for the physicians and the clinicians, I mean, those who are practicing medicine, I mean, it has been a wonderful lecture. Thank you so much and sparing your valuable time. Really grateful.
Thank you so much, sir.
We'll have a more opportunity to listening from you on some platform like API or some other platform. Thank you so much.
Sure. Thank you so much for your kind words, sir.
Thank you. Thank you. And probably this may be the last CME program of my tenure, but I would like to continue the same CME platform in the Dr. Pathak's tenure also, and because it's a very good learning platform and for common diseases which we see every day, and as I mean on a platform like IACM clinical medicine, which is more important to on clinical side, we were looking forward, Dr. MP Singh, for your involvement next year also. Thank you very much, everyone, for your great listening.
So, Parikh, may I comment something? Hello.
Yes, sir. Please go ahead.
Dr. Parikh, in the
Yes,
last 8 months, about the continuous conferences, and what I must say that one of the most important lectures which has impressed me, that's very important for the clinicians, was on hematology from I think Solan. Another was one lecture on diabetic oral hypoglycemia, and 2 lectures today by Pooja and Vinita. Vinita is not here, but she also deserves a appreciation in the sense that she has very vividly explained what to see in chest X-ray, in chest CT. Previous to this occasion, I basically deal with neurology, though I'm a man of internal medicine. But this was the best lecture for the CT thorax to be seen, and it has made us more intelligent to see when we look for. Pooja has also done an excellent presentation. And what I propose as a president of IACM, in the last 8 lectures, at least you must award these 4 speakers as a President Appreciation Award. One for hematology at Solan, another on oral hypoglycemic at
Dr. Virmani. By Dr. Virmani.
I don't remember the name at the moment. And then these 2, Pooja and Vinita. And for both of them, I must
absolutely.
Mahajan, who has actually suggested as the names of these 2 good speakers, which has done the excellent job for this. And lastly, I think you should appreciate your convener, Dr. MP Singh also, and must award him in the National Conference IACM with the Chairman President Appreciation Award. Thank you so much.
Thank you. Those who are not attending this program or could not attend these CME programs, we are putting them on YouTube.
YouTube, yes, they are there.
IACM, so that they can, whenever they feel convenient, they can go ahead with them. So
With this, we come to an end. Yes, sir.
Yes,
With
yes.
this, we come to the end of this CME. Probably next CME would be held in December after the conference. I would like to thank the guests of honor, all the delegates, the speakers who did a wonderful job. This was the first time it would make something sense of a CT chest. Otherwise, I would just see it and then always wonder what it was showing. And I had to always look at the report. Now I can see and make out a few things at least. Absolutely beautiful lectures by both the doctors. And thank you, delegates. Thank you, chairpersons and the moderator. Looking forward to see you again after the conference. Good night, everyone.
Thank you. Thank you. Good night. Thank you.